Iboan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. Today we are going to be talking about a condition which is on the rise, which is none other than the cancers in the bowel. Technically we call it colorectal cancers. And to discuss about this topic in depth, we have invited a very special guest to the Healthline studios today. He is a professor in surgery at the Faculty of Medicine, Sri Jawaharlal University, and a consultant surgeon at the Colombo South Teaching Hospital. He is none other than Professor Bawantha Gamage. Very good evening to you, sir, and thank you for joining us here on Healthline.
Good evening and good evening to our viewers. So we will go through the one of the commonest cancers around the world and in Sri Lanka.
Yes, I think it's a very important topic to discuss and for our viewers to have a understanding about. But before we get into the condition of bowel cancers per se, I think it would be beneficial if we can just discuss a bit about the structure, the anatomy of the intestine, so that they can get a better understanding of what we are talking about as we move along.
Yes, Dilshan, now when we talk about the bowel, there are two parts. One is a small bowel and other one is a large bowel. So basically we are talking about cancers in the large bowel because that is the commonest part of the bowel that get cancers. Large bowel also, I would say there are two parts. One is we call it colon and other one is the rectum. Colon starts from the right side of tummy, lower part of the right side, and that is the origin of the colon. We call that area a cecum technically. Then it has ascending part which comes up on the right side of the tummy, then that is called ascending colon. Then it goes across our tummy to the left side, that part is called transverse colon. Then it descends downwards on the left side, we call it descending colon, and the last part of the colon is called sigmoid colon because it has a sigma shape. So these are the parts of the colon. Then it joins to the structure called rectum, which is about 15 centimeters, and that goes out through our through the anus to the exterior, opens out. So if you take colon, these cecum, ascending colon, transverse colon, descending colon and sigmoid colon, that area, the length of that is about, I would say, 140 to 50 centimeters, and the last part is about 15 centimeters. So that is the normal structure of the large bowel.
So now talking about the large bowel and the rectum, sir, so we are going to be talking about cancers in these areas. So if you can just give us a description on what they are, how common is it, and how is the situation in Sri Lanka when we compare the global scenario?
Yes, when we talk about colon and rectal cancer, we, as you correctly said, technically we call it colorectal cancers. Out of the colorectal cancers, about 70% occurs in the rectum and the left side of the colon. So the balance is in the other part of the colon. And if you look at the incidence in Sri Lanka, it is the 4th commonest cancer, and in the world also it is the 4th commonest cancer, but it is considered as a number 3 killer in all cancers. It is more common, slightly more common in males than females. The incidence is about 4.3% in males and about 4% in females. So that is the roughly the incidence and the distribution.
Now in the general practice, we just feel that the colorectal cancers are on the rise. Is that so? And if it is there a particular reason that we have identified? Is it the lifestyle or the dietary patterns? Is there something predisposing towards this?
Dilshan, all the cancers I would say are on the rise because of various factors influencing. It may be diet, it may be our the working environment. So many factors come into play. But when we talk about colorectal cancers, the risk factors, the main risk factor is the age. When you grow old, every cancer is like that. When you grow old, you tend to develop more and more cancers. However, there are specific risk factors for colorectal cancers other than the age. One is certain group of people have got family history. If your sibling or if your close relation has got a cancer in the bowel, then you are more prone to get cancers. Out of all the colorectal cancers, about 15 to 20% are family related, but majority, about 80%, is non-family related. So, there are other causes which are prone, which if you have them, then or if you are exposed to them, you are more prone to get colorectal cancers. One is, as we all know, smoking is a bad habit which predispose to cancers. Then alcohol, then obesity. If you are overweight or if you are obese, if your BMI is high, then you are more prone to get colorectal cancers. Then also your diet. If your diet is rich in fat and also red meat, we call it. If your diet is rich in red meat every day, like, then you are more prone to get colorectal cancers. That is why this particular cancer is much more common, much more common in the western part of the world than this part of the world. But however, recently we have seen in our part of the world also the incidence of colorectal cancers are going up. One reason is not really the cancer incidence are going up. Our technology has improved, and we are now more and more we are diagnosing colon and rectal cancers much more than what it was. The good news is when we diagnose them early, then the cure rate is high.
Definitely, with is the case with any cancer, the early detection is key, and the outcomes may be much more positive when you identify these cancers early. And that is one reason why we bring these type of discussions to you, so that you have a understanding of what these are about, what the red flags that you should be on the lookout, so on and so forth. Now, sir, you mentioned about family history. So there is some genetic component in these cancers. So if you had a family history, if someone has had a family history of bowel cancers, when should they be screening themselves, and if so, when should they start, and how often should they do it?
Actually, in the developed world, all the people who are above the age of 55 years, they are screened for colorectal cancers. However, we do not have such screening program. Therefore, what we recommend is, if there is a family member who has got a cancer in the colon or rectum, definitely the other family members should be screened. The screening age, there is no strict criteria, but I would say after the age of 40 years, definitely you should have a screening test done, especially if you have a member in your family who has got bowel cancer. Then frequency of testing depends on individual person, and depends on the, if there are symptoms, then you screen them or you subject to tests more frequently than a normal person.
Now, talking about screening, sir, is there a one particular test that you would recommend, or is it in combination? Do we do a sigmoidoscopy or a colonoscopy, or is there a particular blood test that you would want to use?
Yeah, it's very important to know what the term screening means. Now, screening means we have to screen a larger population. So, the test has a specific characteristics. One is that it has to be low cost one, so that we can screen a general population. So, the commonest screening test that was used in UK some time back is known as a fecal occult blood test. We do it here also. Now, there are many, more advanced tests than fecal occult blood test, which is also cheaper. Therefore, I would say fecal occult blood test has been replaced by another test called FIT test, that is called fecal immunochemical test. However, in our country, the FIT test is not commonly available. It is available in private sector, a few hospitals, but common high risk groups, we do fecal occult blood test. So, the fecal occult blood test, if I may describe
yes,
it,
of course, yes.
The person has to test his or her the stool samples 3 consecutive days, and then if at least one test is positive, we consider it is positive, and we step to another set of investigations. Now, there are specific advices we give to patients when you do fecal occult blood test. If the person is taking iron tablets, they have to stop for at least 3 days. If you should not consume red meat for at least 3 days if you are going to get a fecal occult blood test. Then you should not use juices like vitamin C containing fruit juices, or if you are taking vitamin C, we should stop that. So, likewise we give advices and then ask the patient to get the test done. In contrast, FIT test does not need those things. So, FIT test, one test is enough. If it is positive, the chances of that particular person having not even a cancer, there are pre-cancerous stages, we will discuss them. So, chances of such a problem occurring in that particular person is very high compared to the fecal occult blood test. So, then we will subject that particular person to, as you said, sigmoidoscopy or more commonly a colonoscopy.
So, now sir, for the intents and purposes of our discussion, if a person can undergo a FIT test, it will be better than what we used to do the fecal occult blood test.
It is better, yes.
So, it's more specific and more sensitive.
Specific and sensitive. So, accuracy is also high then.
So, which brings me to my next question now. With the fecal occult blood, we were testing for blood in the stools. So, with the colorectal cancers, what are these symptoms that may occur? We know that bleeding from the rectum is one.
Yeah. So, bleeding is the is one symptom, but having said that, there are many other conditions which causes bleeding per rectum. Yeah. So, that is why if you have that symptom, please go and visit and meet a qualified doctor, so that he will ask you few other questions and would clarify what it is exactly. So, that is one symptom. The other thing is the patient's bowel habits can change. Now, if one person is opening bowels once daily, if he or she starts opening bowels 2-3 times daily or maybe more, then that is an alarming symptom. Then the other thing is, other than passing blood with stools, you may start passing mucus or like a jelly like substances with stools. In addition, if once you open bowels, once you done the job, you may again feel like going into the washroom. So, that is, we call it incomplete evacuation. So, those are alarming symptoms. If you have, please go and visit a doctor and then tell him or her about the problems, and then you will need further testing and examination.
Definitely. So, if you have these symptoms, please do not neglect, do not delay. Like Professor Bawantha said, go to a qualified doctor, get yourself tested, because early detection, again I want to reiterate, early detection is key in achieving a good clinical outcome. Now, sir, with these symptoms, patient comes to you, and so we spoke about this FIT test and the sigmoidoscopies. So, does it always mean that we spoke about precancerous lesions as well? So, does it always mean that these symptoms are given by cancer, or if we detect a precancerous lesion, if you can just elaborate on how you would approach these patients?
Yeah, if a patient comes to me and says, doctor, I am passing blood with my stools, or all these symptoms are there, depending on the age of the patient. For example, if a patient is a young guy who comes with these symptoms with bleeding per rectum, my first diagnosis will not be the cancer. The commonest diagnosis in that such a person is hemorrhoids or piles. But then we can't 100% exclude cancers by just listening to a person. So, we need to do few examinations. We will examine the patient, and also we do at least what is known as a flexible sigmoidoscopy, which is not extensive examination of the entire large bowel, but only the left side of the bowel. Now, this sigmoidoscopy is a simpler test, can be done as outpatient, and it detects, as I said earlier, 70% of the bowel cancers occur in the left side. So, this sigmoidoscopy will allow us to examine that left side. So, we will be able to detect 70% of the bowel cancers by doing that. That is why in UK recently they have started flexible sigmoidoscopy as a screening test. That is the test I would do in a younger person. Then when we come to the precancerous states, now cancers will not develop suddenly. So, cancers will develop the first stage of developing cancer is developing a precancerous stage. So, we call them polyps. So, polyps takes sometimes through 3-4 years for it to become a cancer. So, and also these precancerous states like polyps also can bleed. So, that is why I said and polyps can also give rise to change of bowel habits, it can give rise to passage of mucus. So, that sort of thing if you go to a doctor, that doctor will refer you to a specialist who will do this maybe a sigmoidoscopy or maybe a colonoscopy and then detect these precancerous states. If you detect precancerous stage during a colonoscopy, then and there during the colonoscopy these polyps, some of these polyps can be removed and you will not get any pain because the bowel is insensitive to pain actually. So, most of the people worry to go and meet a doctor because they think one thing is they are shy to tell these symptoms, bleeding per rectum, and also they are afraid of detecting a cancer. If we detect this precancerous stage, you are 100% curable and it is not a operation. Then and there during the colonoscopy we remove it and then you go home on the same day. And also if we detect cancers at early stage, we will discuss that in bit, then still they are 100% curable.
Definitely, that is very important information that Professor Bawantha Gamage highlights. So, all these symptoms may be given by a precancerous stage lesion as well. So, do not try to withhold any information from your doctor, do not try to delay the process. Please always go and consult with a properly qualified medical practitioner and be open with all the symptoms and signs that you have, so that they can make a proper diagnosis. Now, sir, I have seen you undertake the most complex of bowel surgeries with regards to these cancers. So, I think you would be the best person to answer this. Now, when a patient, okay, let us say we diagnose a cancer in the bowel, and what would be the treatment options that we would be able to give them? Is it always surgery, and if so, what can they expect during this surgery? Because that is one thing that most of our patients think time and time again, okay, will I have to be away from my work for a long time, will I be bed bound, will I have to take a lot of time, will it be painful? So, if you can just elaborate on that.
Yeah, Dilshan, that is a very important question because that is the worry of the patient and we have to clarify these things.
Yes.
So, if a cancer is diagnosed by doing a colonoscopy or a sigmoidoscopy, then there is a next step is to stage this cancer. So, we have to decide which this cancer is in which stage. So, there are certain tests that your doctor will request you to do to see whether this cancer is confined to the bowel or it has gone beyond the bowel. So, now it depends where this cancer is. If it is in the rectum, usually we do a MRI scan and also a CT scan to see whether it has gone away from the bowel. If the cancer is in the colon, we do a CT scan of the tummy and also in the chest. So, if the cancer has not gone beyond the bowel or it is in an early stage, I would say, the primary treatment is surgery. If it had gone to some other sites or if it is advanced cancers, if it is in the rectum, still they are curable, I would say. So, then a surgeon will see these MRI scans and assess the patient and then decide if it is in the advanced stage. Sometimes still directly we can operate, but if it is gone beyond certain stage, then we will decide to give this patient prior to surgery some sort of modality of treatment. We call it neoadjuvant treatment. So, we refer them to a medical oncologist who will give these patients that sort of treatment and then they refer back to us for surgery. But the mode of surgery is now changing. Now, with the development of all the technology, all the fiber optics, We have now a treatment modality called keyhole surgery or laparoscopic surgery. So, that has made a revolutionary change in treating bowel cancer patients, and their outcome is much better and they go back to their normal work very quickly. So, we treat these people according to a specific protocol, Dilshan. Now, we call it enhanced recovery protocol, and which when I came from UK in 2009, I started implementing that in Sri Lanka, and I would say in 2018 we became the best team in the South Asia of implementing this protocol. So, our average discharge time is about 5 days after surgery. So, if the patient is subjected to laparoscopic colorectal resection or removal of the bowel, average hospital stay would be 5 or 6 days, and they are back to normal working environment after about 2 weeks. So, that is the pathway we give now.
So, that is again very positive information for all our viewers. With the advancement of technology in surgery, we can undertake this type of surgery via laparoscopy or keyhole surgery, which is minimally invasive, and your recovery period is very much reduced now. On a personal note, I have had the privilege of working with sir, and this advanced recovery protocol that you have been following has given a lot of good results, and like sir says, the recovery is very much enhanced. So, now sir, post operatively we see in some of these patients what we call a colostomy, a bag which is placed. If you can elaborate, because most people have seen these bags and they have known people who have had them, and they find it a little bit cumbersome to handle these as well. So, if you can just elaborate what these and are these always permanent, or can we reverse them in certain occasions as well?
Yeah, actually, yes, they are very important question, because that is a very anxious thing to the patient.
Yes.
When we discuss the treatment plan, we always discuss these things with the patient. So, whether patient sometimes come and ask us whether he or she will have a bag. So, first thing I tell them is that we are trying to cure you. We are trying to cure you. Our first objective is to cure you from the disease, and then if necessary we may have to put a bag to you, but most of the time, I would say 95% of the time, it is going to be a temporary one. There are two types of colostomies we perform, actually stomas we perform, I would say. One is a permanent colostomy, other one is a temporary colostomy or ileostomy. We call it ileostomy when we take a small part of the small bowel out. So, now not only these fiber optics and laparoscopy has developed, the devices that we use during these surgeries have also been improved. We now use devices called stapling devices. So, with the stapling devices, very rarely we use permanent colostomies. So, chances of a person getting a permanent colostomy in treating colon and rectal cancers are very rare now. So, most of the times, if they need most of the patients do not need a bag at all, but maybe about 20 to 30% would need a bag, but again it is a temporary bag. We put a bag just now when we remove the part. Now, the bowel is like a, let us imagine the bowel is like a Sloan pipe. So, we cut from two sides and remove the affected part and rejoin these other two ends. So, once we join these two ends, there is a time period necessary to heal this. So, until such healing occurs, some surgeons prefer not to allow the stools to pass through this joint. Therefore, to minimize that, they put a small bag to the patients. So, those bags usually can be reversed after about 4 to 6 weeks time, and there are people who work their normal day to day activities with these bags. So, you do not have to worry much. Now, these bags are now more sophisticated bags are there. So, there will not be any smell, and they can carry out with normal activities with wearing these bags.
So, when we have this bag, basically the stools fill into these bags.
Yes, stools fills into the bags, and we train. Now there are special set of healthcare professionals who train, we call them stoma care nurses. So prior to the surgery, if we think that the patient may need a bag, we always ask their help, and they come to the patients and they talk with the patients, explain how to manage these bags, and explain to the relations how to manage these bags. So patients get themselves well educated prior to the surgery about these things. So they will be able to manage without much of a problem.
So if a patient is having these bags, can they eat and drink as they did before, or do they have to be careful?
No, they are having normal diet. Before we discharge the patient from the hospital, we usually establish their normal dietary pattern. Actually, Dilshan, diet is very important as far as the recovery is concerned. Now, before we operate these patients, we make sure these patients are nutritionally optimized. So there are certain things in this enhanced recovery protocol. We make sure their blood albumin levels are high and their hemoglobin levels are high, because all these factors influence the wound healing and the recovery. So before they are discharged, we will make sure their normal diet is established.
Definitely. Now, after surgery, sir, let's say a patient has recovered and we have ensured that they have been cured. Is there a chance of these cancers recurring? If so, is there a number, percentage that we think might recur? So, if so, then should they follow up even after cure?
Yes, again a very good pertinent question. Now, some people, that is why we initially stage these patients prior to surgery. When we stage them, we decide, okay, this patient should undergo surgery first, or this patient should not undergo surgery first, this patient should undergo a neoadjuvant treatment first. So, once that decision is made, the aim of that decision or the purpose of that decision is to minimize the cancer recurring after surgery. If we operate a patient who should have been subjected to neoadjuvant therapy, then the chances of the cancer recurring is much higher. So, if we follow that protocol properly and subject the patient to surgery, then the chances of recurrence is less. However, there are definitely cancers can recur. Therefore, they need a close follow up for at least 5 years after the surgery. So, for the first 2 years, the chances of recurring that cancer is high during the first 2 years after the surgery. So, the first 2 years we do extensive follow up. For example, if the person has got a bowel cancer and we operate, every 3 months after the surgery we do a particular blood test called a CEA level, and then every 6 months we do CT scans and follow them up, and also if necessary we subject them to serial colonoscopies and see whether the cancer is recurring. The chances of cancer recurring at the site of the joint is much higher. So, we have a close eye on the area of the joint, so with a colonoscope, and chances of cancer recurring elsewhere, not in the bowel, because at the time of our first diagnosis we do CT scans to see whether the cancer has gone somewhere else, but even the most sophisticated scans may not detect minute or tiny lesions which has gone elsewhere. So, then during the follow up we can detect these patients. The cancer, the bowel cancer commonly goes to the liver. So, we screen the liver, and then following up period also we look at the liver very carefully, and if we detect deposits or cancer has gone into the liver, we can operate them, and that can also be resected out and the patients can be cured. So, the close follow up is mandatory.
Of course, even if you have been labeled as cured, it's very important that you follow the properly advocated follow up plan given by your surgeon, because there's a chance of recurrence, as Professor Bawantha Gamage said. So, with the time constraints that we have, we are coming towards the end of this program, but since it's such a very important topic, and if not detected properly, if not diagnosed properly, it can have very serious consequences. So, before we wind up, sir, what is your message to our viewers who are watching, the take home message, if we may say?
Yes, very important. The take home message, I would say, if you have any symptoms related to your bowel movements, if you have bleeding, please go and meet a qualified doctor. Do not be afraid to tell these symptoms to your doctor, and do not be shy, because there are facilities available in this country. Even if you have a cancer, even if it is in advanced stage, we can cure it. And most of these cancers, I would say 90% of these cancers can be detected early if you go and meet a qualified doctor. So, we come across many patients who have taken many treatment modalities and coming very late to medical doctors. So, do not do that. If you have symptoms, please go and meet. Do not be afraid, because most of these symptoms are not cancer due to cancers. They are simple other diseases like hemorrhoids or maybe anal fissure. So, there are many other conditions which can give rise to the similar type of symptoms. That is the message.
Definitely. Now, our healthcare system is very much developed, and we have very capable surgeons and physicians and all specialties of doctors within our system, which is a blessing that this country has. So, if you have any doubt, do not let Google dictate what your symptoms mean. Always go to a properly qualified medical practitioner, and then they will decide. They will take on the burden of diagnosing for you. They will take on the burden of giving you a proper treatment plan. We see so many patients going shopping, if I may say, going around looking for opinions from one after another. Stick to one plan, stick to one doctor, because they will always look at the betterment, they will weigh the benefits and the risks and give you a proper treatment plan. So, if you can follow up on that, I think the results will be optimal for you. Having said that, I want to thank Professor Bawantha Gamage very much. Thank you very much, sir. It has been an honor to have you here, someone of your caliber coming in and addressing our viewers, which will be beneficial for them, and they will find that if they have followed this, they will, if we can at least touch one life, if we can at least help one person to diagnose this early and have a better outcome, I think that is the objective of our program. So, once again, my heartfelt thanks to you, sir, for coming in today.
Thank you very much. Thank you very much for all our viewers for watching us.
So, having said that, it is time to wind up from this edition of Healthline. As I said before, we are going through very turbulent times. People are out on the street fighting for their rights. So, and especially even in the healthcare sector, we are facing some challenges, but we are all looking forward to better times. We are striving for that. So, until we achieve that, let us keep the good fight going, and let us work together for a better Sri Lanka. And with that message, I take your leave, and until I meet you again next week with your weekly dose of wellness, this is me, Dr. Dilshan Fernando, wishing all our viewers Ayubowan.